This is our peaceful end of life theory, and my name is Katie Womack, and our group members are Kelly Phillips, Sarah Smith, and Alex Stewart. The theorists who came up with the peaceful end of life theory is Cornelia Ruland and Charlie Moore. Miss Ruland got her PhD in 1998. She currently works in Norway as the director of the Center for Shared Decision Making and Nursing Research. Her focus now is on difficult decision making for patients who are faced with treatment problems and need to decide what kind of decisions they want to make in their treatment. She also does preference for long-term management and long-term care for illness and disease. So she wants the patient to be involved in their preferences if they are diagnosed with an illness that is going to be a long-term illness. She's also performed a lot of research, and she's a primary investigator in research projects, and she's received awards for the research that she's done. Charlie Moore is the other theorist that's involved in this theory of the peaceful end of life theory. She was actually an associate dean for research, and she's a professor at Case Western Reserve University, which is a nursing school. She got her diploma degree in 1969, then she got her bachelor's degree in 1974. She then got a master's degree in 1990, and she got that one in psychiatric and mental health, and then she got her PhD in 1993. She currently teaches nursing theory and nursing science to students, and she feels like it's very important that they learn about theory and how to develop a theory. She also assists in the theory development and publication of other theories such as this one and then other ones as well. The development of the peaceful end of life theory was actually developed in a course taken by Ruland and actually taught by Moore at the university. Ruland was trying to complete her doctoral degree, and she had to take a theory course. In the theory course, Moore was asked her students to actually develop a middle-range theorist, and this is what Ruland came up with. She actually had just completed a major project in Norway with a group of nurses that treated cancer patients to come up with an end-of-life practice and make it a standard of care. Ruland actually developed the theory, and then it was actually refined by Moore with her assistance. And it's actually considered a middle-range theorist because it actually can be used at the practice level, it can be used in a situation or a health condition. It specifies a certain client population, which is patients who need to have an end-of-life care. And then there's an intervention and an outcome in the theory, thus making it a middle-range theory. There were a couple of theoretical sources that were helped in developing the peaceful end-of-life theory by Ruland and Moore. One of them was the Donabedians model, which discussed the structure, process, and outcomes within the model, and it also kind of touched base on helped define the family system in the model. They concluded from using Donabedians' model that in their theory, they wanted to make the patient free from pain, have experienced comfort, experience dignity and respect at the end of life. They wanted them to be at peace at the end of the life, and they wanted them to experience closeness with their significant others. The other theoretical source used to come up with the peaceful end of life theory was the preference theory. The preference theory actually helped define quality of life in the end of life theory. The empirical evidence used to develop this theory came from two places as well. They used expert nurses, and they did a review of the literature. The expert nurses had 5 years experience, were terminally, in that they took care of terminally ill patients in the 5 years. So they discussed with those nurses what they thought should be included in this peaceful end of life theory. The next place they went to was the review of the literature. When they were reviewing the literature, they were looking at 4 main areas of concern, which was pain management, comfort, nutrition, and relaxation. They used this evidence-based practice in these 4 areas to help develop the theory. And also within this peaceful end of life theory developed by Ruland and Moore, care is still at the center of the core of this theory. The primary source for the theory was actually first published in Nursing Outlook Journal in 1998 by Cornelia Ruland and Charlie Moore. The title of the journal article was Theory Construction Based on Standards of Care, a proposed theory of the peaceful end of life.
I'm going to discuss the major considerations for the middle range theory of peaceful end of life. This theory takes into account the patient as well as the families, and the end-of-life situations can be very important for a person who is going through an end of life situation to have the people that they love and people that care about them close to them in order to be able to have a nice experience. The nursing paradigm is considered in this mid-range theory. You look at the client, the person, the patient. You want them to be pain-free, keep them comfortable. You look at the environment. You want it to be a comfortable environment, a soothing environment, free from a lot of stressors. You look at their health. You don't want to try to overdo with major technologies, but you want to be able to use the technology and keep them comfortable. Nurses are very important to the end of life process. It helps them to interpret and see how things are going with the process of the end of life. The major central concepts and definitions of the mid-range theory of the peaceful end of life. Being pain-free is a very important aspect of this concept. Many things lead to how a patient perceives a peaceful end of life. Being pain-free is one of those major aspects that we see all the time when people are going through the dying process. Keeping them comfortable is kind of the same deal. Keep the temperature in the room comfortable. Keep low stimuli and give them pain meds as they need. We want to treat the patient with respect and dignity. We want to make sure that we try to keep everything as private as we can. Always yes ma'am, no ma'am. Keep them at the top of the respect. Make sure they're at peace. Offer them spiritual services that the hospital may have. Let their clergy come in, their pastor. Let whoever they would like to speak with, or just talk with them, be there to listen to them, be a shoulder for them to lean on, if you will, when they're going through this. Also, letting their significant others and friends and family be a part of this process is important in the end of life process because closeness of individuals helps the transition from life here on earth to the afterlife. Major assumptions of the theory. End-of-life experiences are individualized and are personal. Everybody responds a little differently. Everybody has a little different reaction to how they view the end-of-life process. Nurses are very important to this process. The nursing care that we provide, nurses are responsible for interpreting and implementing ways to help keep people comfortable, keep them from being in pain. We can also facilitate the presence of family. Through the process, we're able to encourage people to be a part of the care that is received. The big goal with end-of-life experience is not to overuse technology and to try to get a cure, but it's to use the technology and comfort measures judiciously and to achieve a peaceful death. Theoretical assertions. For nurses, a big thing is to monitor and prevent pain. You want to just make sure these people are as comfortable as possible. You want to make sure that their family and significant others are involved in their care and the decisions that they have to make at end-of-life processes. Another big thing is to be an emotional support system. Their significant others can be that support system. Pastors and the nurses are a big part of us. Emotional support too. We're there. We can listen to what they have to say. We can pray with them. We can help them get spiritual guidance in whatever way they would like. And a lot of they just want to have somebody to talk to that's just there to listen. And nurses are very capable of doing that, and I find that we do. Ensuring all the above is what helps people who are going through end-of-life process have a peaceful death experience. It lets them have a easier transition into the afterlife.
I'll be presenting the schematic model of the peaceful end of life theory. The model describes the relationships of the concepts presented within the model. Some of the concepts within the model include not being in pain, experience of comfort, experience of dignity and respect, being at peace, and closeness to significant others and or people who care. The relationships of the first concept, not being in pain, include monitoring and administering pain relief and applying pharmacological and non-pharmacological interventions. Some of the things that describe the second concept of experience of comfort include preventing, monitoring, and relieving physical discomfort, and facilitating rest, relaxation, and contentment, and also preventing complications. Some things that describe the third concept of experience of dignity and respect including the patient and the significant others with decision making in the process of the end of life process, treating the patient with dignity, empathy, and respect, and also being attentive to the patient's expressed needs, wishes, and preferences when it comes to end of life. Some of the things that describe the fourth concept, being at peace, include providing emotional support for the patient and the family, monitoring and meeting the patient's need, which includes administering anti-anxiety medications when the patient needs them, inspiring trust, and providing the patient and significant others with guidance and practical issues, and also providing physical assistance of another caring person if desired. Now, the fifth concept of the model, closeness to significant others and persons who care, it is described by facilitating participation of significant others in the care of the patient who is experiencing end of life, attending to significant others' grief, worries, and questions, and also facilitating opportunities for family closeness. Form used to develop this theory of the peaceful end of life is inductive logic and deductive logic. One of the unique features of this logic is that it was actually developed from a standard of care from a university hospital in Norway. Expert nurses developed this standard of care because they had a lack of direction as to how to care for these patients that were faced with terminal illnesses, and the standard of care was in a gastrosurgical care unit in this hospital in Norway. The logic used for this theory is very straightforward, and it was very clearly stated. This theory is used throughout the nursing profession for end-of-life care. It has been used to develop further researches. It has been used in education courses for teaching purposes, and it has been used to further advance nursing practice. Beckstrand, Callister, and Kirchhoff used the theory to develop a further descriptive research study. And then Kirchhoff and other colleagues also used this end-of-life theory to develop a continuing education course for critical nurses. And many, many other works have been produced from this theory.
Smith, I'm going to talk to you about the implications for future nursing practice. The peaceful end-of-life theory can have many implications for the future nursing practice for advanced practice nursing. More and more advanced practice nursing are practicing in acute care settings and treating patients that are acutely ill or terminally ill. The theory offers basic guidelines and principles to help guide the treatment of patients that are terminally ill and help with their end-of-life care. It can be a trying time for the families, the patients, and even the healthcare providers. It's very stressful. It can help offer a guideline to help comfort these people in their time of need. It helps advanced practice nurses provide for the patient and their caregiver wishes. It helps with pain control, comfort, and emotional support at the end of life. About the clinical scenario. In our scenario, we have Lucas, who is a 56-year-old male. He's admitted for diabetes, an exacerbation of his chronic kidney failure with other complications. His condition has only been worsening over time, and he's decided that he no longer wants to pursue treatment and just wants palliative care. He wants no life-prolonging measures, no ventilator, no feeding tube, no artificial means of life once he continues to worsen. He, his family, the nurse practitioner, and the physician overseeing his care, they're all in agreement on his plan of care, and he's included in the plan of care as much as possible. Pain medication is given. He's offered anti-anxiety medication to relieve any anxiety he's feeling about what may be going on with him. He's offered other comfort measures such as relaxation, trying to distract him, anything to keep him comfortable. The patient's family is encouraged to spend time with the patient as much as possible. They're offered ample opportunities to spend time with him. They're encouraged to participate in his care as much as possible. You want as much emotional support for the patient as possible. Also, the nurse and nurse practitioner, they try to build a trusting, caring relationship with the patient. They try to answer any of the patient's questions that he may have, provide emotional support whenever possible, even if the patient just needs somebody to listen. Also, Lucas just receives comfortable, pain-free care, end-of-life care that's compatible with his wishes. Summary: peaceful end-of-life theory is a relatively new theory that was developed by expert nurses and based on standards of care. The theory is based on 5 major concepts. These concepts are the patient not being in pain, the patient's experience of comfort, the patient's experience of dignity and respect, the patient being at peace, and the patient's closeness to significant others and those who care. The theory of peaceful end of life is useful in providing end-of-life care to acutely and terminally ill patients. We hope you've enjoyed our presentation on the peaceful end of life, and thank you for your time.